This is Walter Kemp. This is Hypertension Part 3. This first is the Bitterroot Valley. It's south of Missoula, between Missoula and Hamilton. I always used to just like driving down there, taking pictures. Beautiful view of the mountains, the river that runs through it, the Bitterroot. I'm blanking the name of the river, sorry, but it's just very beautiful. So anyway, that's better than this. So there's Hypertension Part 3 is this. I had Hypertension General Features, Hypertension Part 2, and this is my 6 lectures on atherosclerosis and hypertension. This is the 6th one of them. 2 websites for questions Dr. Hughes and I made. Like I said, there's about 500 or 600 between the two of them. Probably need to work on that again, but that's what they're right now. The first is my Twitter that I haven't posted in a while, but I'm going to start again, hopefully with some of this. And then just remember, I'm a forensic pathologist, but I have a really strong interest in general pathology and in organ pathology, especially the heart, and I really enjoy teaching medical students, and that's why I'm making these lectures. So since anybody can view these lectures, I always want to put some disclaimers on here, so please read the disclaimers. If these apply to you in a negative way, then don't watch the video. Okay, I want to teach people pathology, but I can't have people watching it who should not be watching it for the right reasons. And then third disclaimer, same thing. And so if none of those apply to you and you want to learn pathology, please continue to watch. If you're interested in knowing how I teach or anything like that, there's an introductory lecture I made. Like I said, very few people viewed it. That's fine. But if you're interested in knowing kind of my theory behind stuff, what I've learned, stuff like that, there's there. These are my references. Start each lecture out with 1 or 2 questions. The idea is, so pause, go through it, read it, try and answer it. The idea is you haven't been exposed to this stuff, and then the answer will answer the question at the end. But what it does is it makes you key in as you go through the lecture and learn the material better, and they've shown it increases retention. Okay, so this lecture is pretty much going to be on causes of secondary hypertension. So this is, to me, this is a really great topic because number one, I think they're great, unique type of conditions that can actually be good test questions. The other thing too is, remember, while 90 to 95% of cases of systemic hypertension are essential hypertension, meaning there is no underlying specific one thing you can point to, 5 or 10% are these. And if you can identify these as a physician who treats patients with hypertension, you can make a significant difference in their life. And since hypertension is such a common disorder, this would be a really good way to affect a lot of people. So I think it's a great topic to learn. So chronic renal disease, which is interesting, it both causes hypertension and is a cause of hypertension. Primary aldosteronism, when you save sodium, you save water, you increase blood volume, you increase blood pressure. Renal vascular, when you affect the renal vasculature, and I have an interesting question on this. Pheochromocytoma, catecholamines play a big role in vasoconstriction, and pheochromosomes are putting out catecholamines. Coarctation of the aorta, congenital disorder, but it blocks basically the beginning of the aorta, so it's increased blood pressure. And then Cushing syndrome, hypertension is one of the components of that condition. So one thing it says, when you suspect somebody with secondary hypertension, it's good when somebody comes in and has a diagnosis of hypertension to have an initial evaluation to actually consider these diagnoses. The other thing would be is if you're treating somebody for hypertension and that hypertension is either really severe or it's really refractory to treatment, might be a time to step back and consider these conditions. So chronic renal disease. With chronic renal disease and with uremia especially, they can affect basically any organ system. With renal disease, you're going to get elevated BUN, elevated creatinine, and then reduced glomerular filtration rate is what you're going to see. Pathologically, we've talked about hyaline arteriolosclerosis several times, and it actually looks the same in hypertension or diabetes, just different mechanism of formation. In hypertension, they say that they believe that the hypertension causes damage to the intima and allows plasma proteins to get in the wall, and that's that acellular thickening. Whereas in diabetes, it's the accumulation of advanced glycosylation end products that causes the acellular thickening. But about 70% of cases are due to hypertension or diabetes, very important one to know. And then glomerulonephritis can be another cause of chronic renal disease. So the top is a normal kidney. You see some little grooves here and there. That's from the kind of a persistent fetal lobulation, but in between it is very smooth. Whereas that hyaline arteriolosclerosis, you can see that granular surface. And when I see that, it usually means person has hypertension, they have diabetes, they have advanced age, or rarely they've had some type of glomerular disorder. Primary aldosteronism. With this, basically with aldosterone, it makes you save sodium but lose potassium. So basically, laboratory-wise, they'll have a low potassium, and then they can have weakness and muscle cramps can be some of the features of it. And so what this is a tumor of the adrenal cortex. Pheochromocytoma, which we'll talk about later, is a tumor of the adrenal medulla. And that's where the epinephrine and norepinephrine are made. You'll see a nodule. Now, it's very common at autopsy for us to see adrenal adenomas. Very common, but most of them are non-functioning. But in one that's producing aldosterone, or can be called Conn syndrome, that can be associated with hypertension. The other thing, too, is that I was always taught that adrenal glands, when they were nodular, because at autopsy sometimes we won't see that nice thin cortical strip, we'll see a nodularity of the cortex, and I was always told that that was due to the hypertension, and it might actually be the underlying cause of their hypertension. So it doesn't just take a single mass. You can actually have bilateral hyperplasia of the adrenal glands could also contribute to increased aldosteronism. And it says this is pretty common, so 10 to 15% of cases of the secondary cause of hypertension, so could be, or as many as 10 to 15% of any cases of hypertension. So very important to consider. And I'm sorry, I left that one in, but I'll just leave it in there so it's a little bit closer up. But that's just an adrenal adenoma. From this, like I said, most of ours are non-functioning. One way you can tell is if it's functioning and it's producing something that would act back on the adrenal gland, the rest of the adrenal gland can atrophy. Okay, renovascular. This is something affecting the renovascular, the renal artery. Says about 1 to 2% of cases. And so what you'll hear is anytime you have obstruction, you might hear a bruit. So that's what you can see. And one interesting thing, it says that with renal artery stenosis, if you use an ACE inhibitor, you can get a first dose hypotension. That can be actually a sign of the underlying disease process. So there's different types of things you can get with the renal artery. You can get stenosis due to atherosclerosis, and you can also get fibromuscular hyperplasia, fibromuscular dysplasia, which usually affects more commonly younger females. So if you had hypertension in a younger female, you'd want to suspect potentially the possibility of a fibromuscular dysplasia. And so what I've shown there, this is actually the atrioventricular node. This is fibromuscular dysplasia, the atrioventricular nodal artery, but I guess, in my opinion, it would show you similar to what you might see with somebody with fibromuscular dysplasia of the renal artery. Okay, so here's my point to ponder. If you had unilateral renal artery stenosis, so say, for example, you had an atherosclerotic plaque on one side that blocked blood for that kidney, what will each kidney look like? And this is a really good thing for kind of anatomy, physiology, pathology all at once. So pause, think about it, and then we'll go on to the next one. Okay, so what you're going to see is obviously the side where the stenosis is. So to this one would be the kidney to the left would be affected. Wherever the site of stenosis is, there's going to be less blood flow to that kidney. So it's going to be atrophic because it gets less blood than normal. However, that kidney also thinks that blood pressure is low. So what it's going to do is it's going to activate the renin-angiotensin-aldosterone system and raise the blood pressure until it thinks it's normal. The problem with that is the other kidney is hypertensive. So to get the blood pressure through that site of stenosis enough so the kidney thinks it's normotensive, the rest of the body is actually hypertensive. So the other kidney will feel the effects of the hypertension. So it will be the one that's normal size but granular because it's the one that gets the hyaline arteriolosclerosis. So I think it's a neat way of looking at the anatomy, physiology, and pathology in this. And this person also has an incidental aneurysm right there, which doesn't really do that. But anyway, so yeah. So I think it's just a neat use of the material. Okay, so we talked about adrenal cortex tumors. Adrenal medulla tumors be a pheochromocytoma. This one will produce kind of a darker mass in the adrenal medulla. And what they'll do is they're really well known for having episodic features, and episodic hypertension. And so what that means is just episodes of it, which would go along with what it means is basically the pheo is not producing norepinephrine releasing it constantly. It produces it basically in boluses. And when it boluses it, they get an episode of hypertension. And so associated with that, they'll see palpitations, sweating, headache is a feature of potentially higher blood pressure, tachycardia, same effect based upon the catecholamines. And so what you can see with this is an elevated serum or urine catecholamine level or vanillomandelic acid, VMA, or metanephrine. And I've seen both those used in tests and stuff like that. So a really good one for identifying this. So a pheochromocytoma has a very classic presentation, that episodic hypertension, and then some characteristic lab features, and it's a disease process that's very important. The disease by itself is usually not malignant, meaning it doesn't invade or metastasize, but it can definitely affect the patient by producing the epinephrine, norepinephrine. So to the right of it, that's a gross appearance of a pheochromocytoma, and below it is actually microscopic. So they kind of describe what they call a Zellballen, Zellballein, if I'm spelling correctly, pattern where it kind of looks like little nests of it, which doesn't really show up the best there. So I just put that in there just for something else to add to the slide. Okay, so this is a break in the pathology. This is Big Sky, Montana. This is when I went there for the only time I've been there one time for skiing. I went to the Montana Society of Pathologists meeting. There were 16 pathologists. It was like half the pathologists in the state. So anyway, we went skiing on our own and went up there, and it was icy, really icy, and I didn't want to ski and everything. And I looked, and there was one run down the one of the lift lines, main lift lines. They're called Iron Maiden, and I'm a big fan of heavy metal, so I thought, I gotta go down Iron Maiden. So I went down Iron Maiden like 5 or 10 or 15 times. So. Okay, coarctation of the aorta. So coarctation of the aorta is where you basically have a congenital lesion where you basically have a tightly stenotic region in the aorta, usually pre-ductal arteriosus, usually in kids, post-ductal is in adults. And so what happens is it causes blood pressure higher in the arms and the legs, higher in the upper extremities and the lower extremities. This would make sense because the between the upper extremities and lower extremities is the coarctation. So above it, it's going to increase the blood pressure, trying to get blood through that coarctation. So that's going to increase in the upper extremities. And once it gets through the coarctation, the blood pressure is going to drop lower in the lower extremities. You get a mid-systolic murmur when the blood is pumping through that corked, and then also because the blood has a tough time going through the aorta, the cyanosis, it'll take alternate routes. So it goes through the intercostals and you'll get enlargement of the intercostals, and then that can lead to actually scalping of the ribs, and then obviously you also get left ventricular hypertrophy because the left ventricle is working really hard. And I put in there the location, and that's commonly associated with the bicuspid aortic valve. So this is a case I saw. This was a guy, I think was in his early or late 40s, diagnosed with hypertension, never treated, never known until autopsy. What he had was a coarctation. So at the top of it, you can see the aorta. The red line is pre-coarctation. The black line is post. In between of it, you see the white line, which is the coarctation. So you can see how much it was narrowed through there. When I was opening up the aorta, I was cutting down the aorta with my scissors, and I was like, why can't I get through there? It was a coarctation. The bottom right is the cardiac hypertrophy, which the section there doesn't really do it justice. You'd need to know the weight of it. And the left, it was actually a bicuspid aortic valve, which is commonly associated with it. So most people, I believe, with coarctations have bicuspid aortic valves, or a fair number, but most people with bicuspids don't have coarctation. Cushing's syndrome. So with this, this is something you'll learn with endocrine, but they have central obesity. They can have waist in the arms and legs, moon faces, so a rounding of the face, hirsutism, so body hair out of proportion what they should normally have, and then the hypertension, about 75%. So it's a common component of Cushing's syndrome. The thing I read said the most 3 common things are thin skin, osteopenia, and ecchymoses. Characteristically, you can get an ACTH secreting pituitary adenoma or cortisol secreting adrenal neoplasm. And so to the right of it, I couldn't find a gross picture. I have a couple of pituitary adenomas, but I couldn't find one when I was making this up last night. So anyway, I put in the microscopic. So if you look at to the bottom right, you can see some, the cells look relatively, you see the 3 types there, the basophilic, the eosinophilic, and then the ones that don't have a color. And then the top left is basically just basophilic cells. So that's the adenoma. So then I just put kind of a summary. When I teach students how to do a differential diagnosis, the best way I think is to go from very general to very specific. So if you think about general categories, so instead of somebody asks you, give me a differential diagnosis of secondary hypertension, you go, okay, first of all, well, we can have it in the kidney, we can have it in the endocrine system, we can have it in the cardiovascular, we can have it in the brain. Okay, and then go to the kidney. Okay, what can do it? Well, you can have the kidney itself, so chronic renal disease, the blood vessel supplying the kidney, the renal artery stenosis, or something in the kidney, a tumor producing something like a reninoma, like I talked about. So if you do things like that, I think you can come up with a better differential, but by going from more general to more specific in an organized fashion. So it was neat when I taught this at students at UND. They said a lot of the clinical doctors would teach them the same thing, so I felt like I was going somewhere in the right direction. So this is just mine for hypertension. And I'm going to end this with kind of an interesting case, interesting pathologically, not for the patient, of course, but this was a patient who died from a ruptured berry aneurysm. So at the top left, you can see the basilar surface of the brain. You can see all the dark blood at the bottom. There's a subarachnoid hemorrhage. This was when I first was shooting digital pictures, which was quite some time ago, and I had a difficult time with the balance, and so it didn't turn out the best. But the bottom right is the circle of Willis, and the black arrow shows it's a vertebral artery aneurysm. That's what ruptured. So this individual died due to a subarachnoid hemorrhage due to a ruptured berry aneurysm, but they had this. So what had happened, the person had gone into their primary care doctor a couple days before their death complaining of back pain. And the doctor put him on a non-steroidal and sent him home. And it turned out what had happened is they had had an aortic dissection. So the white arrow shows the lumen of the aorta, and everything you see there is blood in the media. So what happened is this person had what I talked about when I gave that part of the lecture. They had a tear in the intima. They dissected blood through the media and then tore back in the intima. So there was maybe a 6, 7, 8 centimeter segment of aorta that had blood in the wall. Not enough blood for somebody to actually probably even become symptomatic from it, relatively small amount. And because it never ruptured through the adventitia, it didn't cause them significant problems at that time. Unfortunately, for the physician, if they would have died from that, they would have misdiagnosed them. So these are always concerning to me. It's easier in forensics. You look back at it and see, but a lot of people are coming to you in back pain. Just be aware of this is one of the ones that can be causing it. Okay, so here's the question. So pause, answer it, and then we'll go through it. Okay, so 41-year male who has been diagnosed with hypertension for 2 years presents to his physician complaining of weakness, which he says comes and goes. Physical examination reveals a blood pressure of 152/81 millimeters of mercury, but is normal otherwise, including heart and lung sounds, meaning his physical exam is normal otherwise. Laboratory testing reveals an elevated concentration of sodium and a decreased concentration of potassium in the blood. A CT scan of the abdomen reveals a nodule in the right adrenal gland. Additional laboratory testing most likely reveal an elevated concentration of which of the following? So the answer is aldosterone. So an adrenal adenoma producing aldosterone would cause increased sodium, which is going to save water, which is going to increase blood volume, which increases blood pressure. It's also going to cause a loss of potassium. That would explain the nodule, and that would explain why they have blood pressure. So like I said, for me, these secondary hypertensions have always been a really interesting area. I really like writing test questions on them and stuff like that, and I think they're a great one because a lot of them have very characteristic clinical features and stuff like that, and it's a very important concept not just to ascribe all your patients with hypertension with essential hypertension and be aware of sometimes that patient has an underlying treatable cause. So, okay, so once again, use reflection. Go back and think, okay, what are 5 things I learned during this lecture? I hope you've learned 5 things during the lecture, and then this really helps you cement that material. And as I said, I'm not going to give you a summary slide because that would kind of defeat the purpose. So just do that, reflect, go back, think about what you learned from the lecture, and that's it. And then this is Big Sky, Montana. This is where the town is. So that's the end. I hope this lecture has been useful to you, and thank you.